Hi guys, welcome back. The next topic that I'm going to teach you is Guillain Barre syndrome. This is a progressive neurological disease of fast onset. It can result in development of flaccid paraplegia, quadriplegia, and even a diaphragmatic paralysis in a person, which could actually necessitate a elective intubation and then a requirement of a positive pressure ventilation. I will be describing this illness in a case-based format before you. But first of all, I need to explain the etiological agents which are responsible for GBS, and one of the entries, the recent ones, is COVID-19. You see, this organism has obviously been dominating the news from 2020 and obviously going on into 2021. And prior to this, in 2019, it was Zika virus that was hogging all the limelight. You see, we used to study two problems with Zika virus from the neurology perspective. One is that if a pregnant lady will get infection with Zika virus, then a baby can be born with microcephaly, and that aspect I've discussed separately in the infections component. And apart from that, patients who suffer from Zika virus infection can subsequently end up with development of Guillain Barre syndrome. Well, this disease is an example of type 4 hypersensitivity reaction. When I say that, you might say, sir, from pathology domain, we have read it is also an example of type 2 hypersensitivity. I agree to the fact that this disease per se will be having both a humoral immunity component as well as a cellular immunity component. But on a comparison basis, if you have to select a single best response, then I would suggest you to remember type 4 hypersensitivity. If you need a reference for it, you can definitely mail me across at marvamedicine@gmail.com, and I'll be happy or glad to assist you. The problem in this disorder would be that of demyelination. And where is this demyelination occurring? The demyelination is mainly involving spinal cord and the peripheral nerves. So therefore, the manifestations that will develop in this person will be that of lower motor neuron lesion. And subsequently, I'll be describing transverse myelitis also before you. So you will need to listen to the two cases on a comparative basis. Let me just add on to other organisms that have been incriminated in causing Guillain Barre syndrome. That would be Epstein-Barr virus. The next one is actually important, hepatitis E virus. When we study about hepatotrophic viruses, we definitely talk about illnesses like serum sickness and essential cryoglobulinemia that can again have neurological presentation of stroke. But today I want you to remember hepatitis E. Subsequently, once he has recovered from the hepatitis component, can result in GBS as well. The next entry is autoimmune disorder, that is SLE, and then is rabies vaccine. Here I would like to add that not the current rabies vaccines, the latest generation rabies vaccines are HTCV, the human diploid cell vaccine, or the virocell vaccines. Nowadays, we are obviously using the advanced version, but in earlier times, you would have read these vaccines were derived from the brain of a mouse. So we used to read the word neural derived vaccines. So the older generation of rabies vaccines used to contribute to development of Guillain Barre syndrome. And overall, I would like to say that this is not the commonest organism, that the one that I'm writing now is not the commonest organism, but most MCQs that are asked on this topic would actually begin by describing an episode of acute dysentery in an individual who was maybe driving on the highway. He ate food at some local restaurant, and then he's going to end up with development of fever and blood in the stools. Please remember the fact that the leading cause of dysentery in India per se would be Shigella. You're aware from your microbiology classes that Shigella flexneri is an important cause of dysentery. So by looking at the face of a person, obviously I can't make out whether it is Shigella or whether it is Campylobacter jejuni. I just want you to understand that when this person will come to you the very first time, at that point of time, you will not even be aware of the fact that what is the neurological complication that will develop in this patient in future. I am initially treating this case as a routine case of dysentery, so I have prescribed fluoroquinolones. If I will be suspecting, let me say, entamoeba histolytica, that is amoebic dysentery, I might give fluoroquinolone with ornidazole as well. And the good news is that in the initial consultation, when I prescribe him these antibiotics, he start taking them, he will definitely have a clinical recovery from the current illness per se, that is the dysentery component. Neither this patient knows at the moment, and neither do I know what is going to happen to this patient subsequently. And therefore, something like about 2 to 4 weeks later, that is when this person will develop neurological complications. The bad news about the disorder is that it can occur suddenly. From the patient's perspective, I'm saying suddenly because he cannot obviously correlate that the previous gastroenteritis/dysentery episode is the trigger which is resulting in antibodies, and then a type 4 hypersensitivity working in sync resulting in demyelination. The initial presentation of this guy will be that of weakness in both his legs. Like this guy is young guy, maybe 25, 30 years of age. He woke up in the morning and he's not having any power in his legs. Now, think from a non-medical's perspective. If a person wakes up with less power in his legs, or he can't move his legs, he might think that he might have slept in some wrong position that resulted in compression of some nerve, which is resulting in him having this difficulty in moving his legs per se. So he may be called out to his mom or maybe called out to his dad, and you have to think this from a perspective of non-medical, right? And they're rubbing his legs, or maybe they're applying some oil over his legs. His mom is rubbing the soles of this guy because she's scared. My son woke up in the morning and he can't move his legs. There would be flaccid paraplegia to the level that this guy will not be able to stand up, and if he takes the support of his arms, because at the moment the power is not lost in the arms, he might actually try to raise from the bed using the support of his arms, but when he will try to stand, the legs will not be able to rather take the weight of the body because there is flaccidity, and this guy is gonna fall. This is going to be definitely emotionally a very sad perspective for both this patient as well as this person's parents as well, and he would be rushed to the hospital. There's a possibility that his mother or sister or brother is telling you when he's brought to the hospital after a few hours that at least in the morning he was not having any power in his legs, but by evening, by the time they reach you, there's a possibility that he cannot even sit in the chair. You see, like you and me can sit in the chair because our truncal muscles are able to maintain the posture. But in this case, because even truncal musculature will undergo flaccid paralysis, so therefore this guy will tend to, maybe fall on one side, and you will have to put pillows behind the back of this guy to ensure that at least he's able to sit. The disease will progress now even so fast that there can be even arm paralysis developing in this guy. And if biceps is paralyzed, that is bad news, because one of the root values of biceps is C5. You see, the root value of biceps is C5, C6. If C5 is involved, this means that the demyelination is occurring in the cervical part of the spinal cord, and C5 shares a common root with the phrenic nerve also. So once the arm weakness will develop, I am really worried about this guy, not only because he has developed a fast onset quadriplegia in a matter of, let me say, 24 hours. I am worried about this guy because I think, and that my worst fears will definitely come true, because these patients will end up with diaphragmatic paralysis. In fact, I want to say that biceps weakness or biceps paralysis in a Guillain Barre syndrome patient actually tells you that the disease has progressed to the cervical spine. The demyelination will obviously occur in any area of the spinal cord. You see, you will lots of time see the pathologist using the term segmental demyelination. I'll use this term subsequently also, but I just want you to remember this term because this helps you rather relate to the manifestations relatively better, that there's a patchy involvement. Like for example, I might say later bladder and bowel are spared. So you might say, sir, how is it possible if you're saying demyelination? Because it is patchy. So bladder and bowel may not be involved also. Segmental demyelination helps you understand the disease manifestations relatively better, and unfortunately this guy has now been admitted into my intensive care unit. We have electively intubated the person and put him on positive pressure ventilation, and in some cases, because recovery might be delayed, you might even have to do a tracheostomy in this guy. And lots of time in our country, due to lack of medical facilities, you see, if he is not intubated on time, the carbon dioxide values in the body will continue to rise. This will contribute to development of respiratory acidosis. And why am I scared about acidosis is because acidosis can damage the blood-brain barrier, contributing to brain swelling and encephalopathy. Acidosis can damage the heart, contributing to arrhythmias. If the patient is not given ventilatory support, these patients can actually expire due to type 2 respiratory failure, which is secondary to the diaphragmatic paralysis. You can see the person is having hypoventilation now. And it is not the end of the story. The paralysis will obviously extend very fast. Now there's a possibility that even there might be neck weakness developing in this guy. And this is not the end of the story. There's a distinct possibility that in this same individual, now there would be development of neck floppiness. Like you can study in the library for the whole day, or you're sitting in your house, in your room, in your table and chair, and you can study the whole day because your neck muscles are so strong that you can sit like I am sitting at the moment, and I can focus in the computer screen in front of me. But in this case, there would be a distinct neck floppiness that would be occurring, and subsequently he can ask you which cranial nerve is involved in this condition. You would notice that in GBS there's a possibility of patient developing a bilateral seventh nerve palsy. You're aware of the fact that Bell's palsy is the unilateral seventh nerve palsy, but here I have used the word facial diplegia. Medical disorders where you read about facial diplegia could be sarcoidosis, non-caseating granulomas involving the seventh nerves bilaterally. Then can be Melkerson-Rosenthal syndrome. And then is the topic that we're studying, that is Guillain Barre syndrome. In fact, the infective cause that I'm not writing at the moment, but you will notice me writing subsequently, is Lyme's disease, because at the moment I don't want to get into another infection and then say that it's going to cause neurological manifestations. I want you to remember that the most common cranial nerve involved in sarcoidosis is also the seventh nerve, and the most common cranial nerve involved in Guillain Barre syndrome also happens to be the seventh nerve. Subsequently, even feeding problems will occur in this person. The same patient will now not be able to, let me say, sip tea or coffee, or let me say his mother gave milk to this guy, right? She put haldi in that milk. Like, if somebody falls sick in India, what they do is they put haldi in milk and they think that it will give strength to the person, right? Turmeric. So she tried to give something to the child and it's coming out of the nose, or he might even aspirate and die. So bulbar palsy can definitely occur in these patients. The manifestations of bulbar palsy can be that if the ninth cranial nerve, the 10th nerves, and especially the 12th cranial nerves are involved, the lower motor neuron lesion related to these nerves will definitely cause problems in talking, problems in speaking, problems in especially drinking. So when you read the word can't drink, can't eat, can't talk also. Why? Because vagus nerve is vagus is going to be controlling the voice box. So this person will definitely now be in a dicey situation, to the risk of even developing an aspiration pneumonia, especially if somebody in the family tries to give something to him. Like, you see, it's hot in India sometimes, and the family member might think that we have not given him even water to drink for one day. We have just shifted him to the hospital and doctor is not allowing anything orally. So they might just put little bit of water in the mouth of the patient at night, and the patient can aspirate and die. And you all have experienced this so many times in your hospitals, when especially the patient's relatives do not listen to you. The next problem can be autonomic insufficiency. Well, in this particular disease, yes, you can have sensory manifestations also, you can have autonomic manifestations also. So let me explain both of them. Do not be under impression, mark my words there guys, don't be under impression that this is only a pure motor disorder. There can be sensory involvement also, there can be autonomic involvement also. Let me explain to you what I mean by the word autonomic insufficiency here. Fibers from T1 to T4, they are called as cardiac accelerator fibers. Like, for example, if I request you that, doctor, can you do 5 sit-ups or 5 push-ups? You guys are young people, so doing few sit-ups or push-ups is no big deal for you. But when you will do sit-ups or push-ups, then your heart rate will increase. What will increase your heart rate? The sympathomimetic drive that is coming from T1 to T4 via the cardiac accelerator fibers can increase your heart rate. But in this case, because these fibers are demyelinated, these fibers are damaged, so you will notice that these patients can be having bradycardia. Because of this bradycardia component, the BP will also be low. So I can use the word neurogenic shock. Now, since the BP is falling, there is also possibility that the compensatory mechanisms in the body will kickstart. There can be a reflex vasoconstriction, and this reflex vasoconstriction can then result in the same patient to develop rather a spike of blood pressure. So lots of time in the textbook you will read the word wide fluctuations of blood pressure can be seen in patients of Guillain Barre syndrome. Why these wide fluctuations of blood pressure are occurring is what I explained to you. Initially there will be features of neurogenic shock, bradycardia, hypotension, and then the sympathomimetic drive will increase. The remaining system is still functioning, right? I said patchy demyelination, I said damage only from T1 to T4. The remaining sympathomimetic drive in the body is working, so it will cause a peripheral vasoconstriction that can even spike the blood pressure of this patient. So you need to monitor BP of these patients very aggressively. And I repeat once again, don't be under impression that this is a pure motor disorder causing only a paralysis. It can even have sensory implications. If the person can talk, if he can't talk, if he presented late, then obviously he cannot tell you about the sensory complaint. But if he comes early and he can talk, he will definitely talk about sensory complaints. If you ask him what is the problem, not only will he tell you that I can't move my legs, he will also try to tell you that I'm having pain in my muscles. So what is the kind of pain in the muscles he will experience is like if you do exercise after a long time. Like most of doctors, like you guys are preparing for an exam, so most of the time you hardly get time to exercise. You just keep on sitting at one place listening to lectures and keep on giving tests, etc. So if I ask you to do some running for 1 kilometer, most of you will either refuse or even if you manage to do it after 1 kilometer running, you would be having pain in the muscles. So a similar kind of pain that comes in the muscles after exercise is the kind of pain that will be experienced by these patients. I repeat the fact once again, the sensory complaints of these patients would be pain in the muscles of a similar nature as comes after doing a prolonged exercise or exercise that is done after a substantially long duration. Some patients might even tell you that they can feel some tingling sensation in the extremities. Remember, I told you peripheral nerves are involved, and because of peripheral nerve involvement, they can be paresthesias developing in the patient as well. So these are the usual manifestations that you will encounter in these patients. And then I want you to remember that bladder and bowel may be spared in this condition. The reason is, again, I highlighted earlier that there is a segmental demyelination. So it is not a hard and a fast rule, but in majority of cases of Guillain Barre syndrome, you can be having demyelination in the cervical spine, thoracic, lumbosacral, but as you go down towards the sacral S2, S3, S4, usually S2, S3, S4 may be spared, because of which bladder and bowel are spared and the hygiene component will be maintained in these patients. I'm just writing the word plus minus after this to say that it's not a guarantee that it's going to happen in all the cases, but yes, bladder bowel being spared is one of the features that you encounter in Guillain Barre syndrome, whereas subsequently I will teach you transverse myelitis, in which case almost all cases or majority of cases will be having a development of bladder bowel involvement. I repeat the fact once again. In transverse myelitis question, bladder and bowel involvement is usually always almost seen, whereas in this case it may or may not be seen. So that minor technical difference should definitely be kept in mind while attempting case-based scenarios. And most of the time we'll describe a young chap suddenly woke up with inability to move his legs, and that's when he tried to get up and he fell down flat, and his mom has come over, his dad has come over, and they're trying to massage his legs and worrying about what's really going wrong. And the illness can be progressing so fast that within a couple of days, you see, the upper limit of progression, as I'll tell you in the diagnostic criteria, is up to 4 weeks. But the point is, this illness can actually progress over a couple of days, and the patient might become dependent on a ventilator till you get rid of the harmful antibodies which are present here. I'll talk about the treatment part subsequently. But if you get the clinical domain right, especially the combination of motor plus sensory plus autonomic manifestations which are going to occur in these patients will definitely help you in solving the questions on this topic. If he says which is the earliest manifestation, then your answer would be distal areflexia, because first in this patient it is the ankle jerk that is lost, then it is the knee jerk that is lost. So the paralysis goes from bottom upwards. So let me just make you revise what are the manifestations of the disease that I've just explained to you. I said initially the paralysis will occur in the muscle supplying the ankle joint. Then there's going to be paralysis related to muscles of the knee joint, then the hip joint muscles would be affected, and that is why I was saying that he won't be able to stand. The bad news is that even the arms can be involved in this case. Then unfortunately there can be involvement of even the diaphragm. There can be neck floppiness, and there could be even facial paralysis occurring in the patient bilaterally. Bilateral seminal paralysis will occur. I used this term earlier also, but I'm repeating it. There would be ascending symmetrical. Please remember, the paralysis in the left leg will be equal to the paralysis in the right leg. If you check the power of muscles in the left leg versus power of the muscles in the right leg, both would be affected in an identical fashion. So ascending symmetrical flaccid paralysis is the term that I want you to remember for this particular topic. I mean, very characteristic. In contrast, I'll just use a different color to mention that when it comes to poliomyelitis, though poliomyelitis has been eradicated from India, it is still present in Pakistan and Afghanistan. So if you read about descending paralysis of asymmetric nature, then one of the differentials that always have to be kept in mind would be that of poliomyelitis. You see, descending paralysis is what you read even with botulinism also, no? You read that even with diphtheria. There are 3 important causes of descending paralysis that I have just mentioned before you: poliomyelitis, diphtheria, and botulinum toxin. And yes, asymmetrical per se, especially from a developing country perspective, you should definitely keep a watch for answer as poliomyelitis. The earliest manifestation of the disease is distal areflexia. Now, it is not a hard and a fast rule that all cases will be having motor plus sensory plus autonomic manifestations. There is a distinct possibility that in some cases there might be only motor paralysis developing in the patient. If only motor manifestation is occurring in the patient, then the term that we will use to describe that will be called as AMAN, that is acute motor axonal neuropathy. In fact, sometimes you might read the word AMSAN, that would be acute motor sensory axonal neuropathy. What I described before you was having motor plus sensory plus autonomic. The technical term for that would be acute inflammatory demyelinating polyneuropathy. So do try to practice the information that I'm mentioning here before you, especially the terminologies that I want to highlight at the moment. In fact, the commonest presentation of this disease is what I explained to you, that is motor plus sensory plus autonomic. The technical term is acute inflammatory demyelinating polyneuropathy, and then there can be a rare version of this that is called as Miller-Fisher syndrome. Before I describe the features of Miller-Fisher syndrome, I just want to put the vocabulary right. I want you to remember that the broad topic that we're studying is Guillain Barre syndrome. The subtypes can be AMAN, acute motor axonal neuropathy. Then you will read about the term AMSAN, that is acute motor sensory axonal neuropathy. Then is AIDP, acute inflammatory demyelinating neuropathy. This is the commonest presentation of the disease where motor plus sensory plus autonomic manifestations will be seen. And obviously the rare version of this that I'll teach you is called as Miller-Fisher syndrome. This is actually I would call it a complex of various disorders out of which various presentations might actually be seen. Sometimes in questions, they might just ask you the standard information as well, that where is the damage present. So you can notice, as I've underlined in red, that the primary site of damage would be axonal damage with respect to AMAN and AMSAN. But when it comes to demyelinating polyneuropathy, the damage will not only be occurring in axons, but over and above this, even the Schwann cells would be damaged. So do remember this minor aspect, though it's very obvious from English that in AIDP, it is a combination of obviously axonal damage plus Schwann cells. I mean, that is itself a question in which of the following subtypes of GBS primarily Schwann cells can be involved. Then the answer would be given as acute inflammatory demyelinating polyneuropathy. I will now explain about this very interesting term where you read about this triad by the name of OAA. Alphabet O would stand for ophthalmoplegia, and it is here that the question would be asked that which is the cranial nerve involved in this case, then your answer would be given as third nerve palsy. If you're listening to me carefully, you would have noticed that in AIDP, the standard presentation, I was saying facial diplegia and the seventh nerve that is involved, but in this case, you will answer third nerve involvement. I repeat that again, if he just says GBS, which nerve is involved, your answer is seventh nerve, AIDP, seventh nerve, but if he specifies the word Miller-Fisher syndrome, then your answer would be given as third nerve palsy that can contribute to ptosis. Alphabet A would stand for areflexia, that is a standard feature of any lower motor neuron lesion, and then would be ataxia. And if you're getting an impression that I'm talking about any cerebellar involvement, no, I'm not talking about cerebellar ataxia. The ataxia that we see in this case is mainly a sensory ataxia. The triad OAA is not to be confused with the triad of Goa that you read for Wernicke's encephalopathy. I also want to highlight that though it is written areflexia, but along with that, muscle weakness or limb weakness is usually not encountered in this condition. And when I say that, the query that I get from most of the students is that, sir, you yourself said lower motor neuron lesion, then how is it possible that in lower motor neuron lesion, you are saying areflexia is there, but there is no limb weakness? I mean, there should be weakness. No, ideally, lower motor neuron lesion has flaccid weakness occurring in a patient. I mean, AIDP, I was describing, he can't even stand on his legs. He can't even sit on a chair. He can't raise his arm. There's a biceps paralysis. And now, sir, you are saying no weakness. Well, there's a very interesting observation that he has given in Harrison about it. He says that the antibodies which are involved in this condition are the ones which are to blame for it. So let me just first tell you regarding the name of the antibody, which is important from exam perspective. Anti-GQ1 antibody is the one which in this case will be damaging gangliocytes. You see, gangliocytes are, I would say, compounds that you study in biochemistry, which would be present in the nerve lining. Now, he says a very interesting fact. He says nerves are supplying eye muscles. Obviously, nerves would be supplying various muscles in the body. What he says is that the nerves which are supplying the arms, they have less concentration of GQ1, so the antibodies cause less damage. But the nerves which are supplying the muscles of the eyeball, they have a higher concentration of GQ1, so the antibodies against will cause more damage. I repeat that fact. I said when it comes to the nerves which are supplying the eye muscles, they have a higher content of GQ1, the subcomponent of ganglioside, whereas the ones which are supplying the arm muscles are having lesser components. So the antibody will obviously cause more damage where there is more of the target antigen present. As a result of it, eye muscles are definitely involved, but arm muscles are usually spared in this condition. If you can remember the explanation part, it is great, but otherwise, this peculiarity definitely needs to be remembered. Why? Because traditionally, when you read about lower motor neuron lesion, you always will be having weakness present, but in a MCQ Miller-Fisher syndrome, you will answer weakness of arms is not a feature. AIDP has weakness of the arms. AIDP can have quadriplegia, but not MFS. Now I will speak a few words regarding the mnemonic GOA, which is accessory information that you don't need to note down. That is just for your general information. And even the psychiatrist would have talked about it. That is Wernicke's encephalopathy. When we talk about the GOA mnemonic for Wernicke's encephalopathy, alphabet G would stand for global confusion. I mean, this guy, he did not get access to alcohol for previous 48 to 72 hours. Like, this is a hardcore alcoholic. Modi ji has announced a lockdown and all the shops which supply alcohol are closed. So because of this guy who is binging on alcohol on a daily basis, now getting no access to alcohol, there's a possibility that he can develop global confusion, he can develop ophthalmoplegia. And why am I teaching you this is mainly to sensitize you to the fact that in ophthalmoplegia, in this case, the cranial nerve involved is the sixth nerve. So there are three details to be remembered now: seventh nerve involvement in sarcoidosis and Guillain Barre syndrome, third nerve involvement in Miller-Fisher syndrome, and sixth nerve involvement in Wernicke's encephalopathy. And apart from this, there would be ataxia also. What is the type of ataxia seen here? Well, you would be having a combination of sensory plus cerebellar plus vestibular. You see, all these circuits that I'm writing, they play an important role in maintaining balance, and alcohol can contribute to damage to all these circuits. It can damage peripheral nerves, it can damage cerebellum, it can damage the vestibular circuit. As a result of it, the ataxia component will be fairly severe. For management of Wernicke's encephalopathy, you would first be giving IV thiamine to the patient. Well, the logic is that give whatever is deficient. Don't first answer giving sugar to these patients, because a lot of these patients are hypoglycemic also. If you will give sugar first, it will cause worsening of neurological features, because when you give sugar first, when sugar is metabolized, then thiamine will be consumed even more, resulting in development of less thiamine being available overall, leading to worsening of neurological features. You see, in MCQ, he will say IV sugar plus IV thiamine plus IV sugar. It is IV thiamine, fluids and sugar. I mean, this could be obviously in the form of an infusion. But if you give sugar first, then the metabolism of sugar will consume the residual thiamine present in the body of this patient, resulting in worsening. You can definitely be doing a RBC transketolase levels in this person, which will definitely be hampered. In fact, this is itself a question of then thiamine deficiency, what test can be done, then RBC transketolase levels are the ones which are to be done. The main agenda is, however, to compare the manifestations of OAA that I have highlighted initially versus the manifestations of GOA, that is GOA. And because of the overlapping terminologies, like ophthalmoplegia I said for both of them, that's where errors of judgment can occur. Now, if he says which manifestation is the first one to recover, in fact, that's an additional MCQ that I would like to squeeze in here. If he says out of the GOA mnemonic, which is the first manifestation to respond, then your answer would be given as ophthalmoplegia. Don't answer ataxia, as is erroneously given in some books. It is actually ophthalmoplegia, which is the first one to recover. I have highlighted 4 variants of Guillain Barre syndrome. The names I'll make you practice once again are Aman, Amsan, AIDP and Miller-Fisher. I hope you are remembering them at this particular juncture. And now I'll be teaching you the workup of this case. The first investigation that I'll order for this guy would be to perform a lumbar puncture. When I obtain the CSF of this patient, very interesting finding will be seen of albuminocytological dissociation. However, in the question, he may not write the word albuminocytological dissociation. He might just describe the standard findings like this, that the opening pressure was found to be normal. The cells that were found on microbiological examination were normal. I've told you normally we have 0 to 4 cells in the CSF, that is lymphocytes primarily. In this case, the cell count is normal. The sugar is also normal. So when you read the report, you're wondering that what's going on, man? Everything is given to be normal. But since this is an autoimmune disorder, the values of proteins will definitely be elevated. You see, traditionally what happens in CSF is that when cells will increase, that is when proteins will increase. But in this condition, cells are normal, but still the proteins are elevated. I repeat that again. Normally, cells and proteins both go up together. In this case, the cells will remain normal and the proteins will start going up. So when you read this classical term, albuminocytological dissociation, you know that you are dealing with Guillain-Barre syndrome, and because this is a dead giveaway, so in lot of MCQs of ascending paralysis, he might actually avoid writing this word. Also, I want to tell you that don't be under impression that albuminocytological dissociation, if it is written, it is a guarantee, it is a Guillain-Barre syndrome. Albuminocytological dissociation can also be seen in Freund syndrome. Well, what is Freund syndrome? It is a condition of spinal block. Why this spinal block can occur? It could be due to tumor. It could be occurring due to maybe tuberculosis. So, albuminocytological dissociation alone cannot be used to diagnose Guillain-Barre syndrome. We obviously need to do electrodiagnostic tests in this guy. Because I said there is a demyelination, that too a patchy demyelination, I'll definitely do a nerve conduction velocity test. In the MCQ, instead of writing nerve conduction velocity, which will make it easier for you, just to make it a little sophisticated, he will write the term electrodiagnostic tests reveal increased latency period of the F reflex. Listen to the words very carefully. It simply means the fact that the time taken for the current to go into the spinal cord and coming out of the spinal cord is increased. You are all aware of reflex arc. Current goes into the spinal cord, comes back from the spinal cord. In this case, because there's a demyelination, the speed will be less. If he simply says speed is low, that's obviously going to be very obvious, very understandable. So just to make the MCQ look relatively sophisticated, he might write the word F reflex latency period is definitely increased. It simply highlights slow conduction occurring due to demyelination. MRI spine is not a necessity for diagnosis of this condition, but because there are so many other conditions where demyelination can occur, including vitamin B12 deficiency, so I definitely would recommend a MRI spine to be done, though I highlighted, I mean, even if you don't do a MRI spine, your diagnostic process is very clear, but to rule out other causes, because see, if the demyelination is involving the dorsal column, if the demyelination is involving the corticospinal pathway, and especially only some tracts are involved, it's not patchy demyelination, some segments, it is only some tracts getting involved, then along with vitamin B12 deficiency, you can definitely make a diagnosis of subacute combined demyelination. But one of the clinical pointers which is against the diagnosis of subacute combined demyelination for this particular case that we're discussing is that in subacute combined demyelination, because corticospinal pathway is demyelinated, they might be brisk DTR and Babinski sign. Whereas in this case, I never spoke about any upper motor neuron manifestations. Please appreciate the fact corticospinal pathway, wherever it is damaged, whether in the brain, whether in the spinal cord, the manifestations will still be Babinski sign. You see, normally the impression is upper motor means brain and lower motor means spinal cord, but that is technically a wrong term. Nowadays he says don't use the word upper motor, lower motor, use the term corticospinal damage, corticospinal tract, wherever it is damaged, whether in brain or spinal cord, the implications would be a brisk DTR and a Babinski sign. So upper motor neuron manifestations are not present in this case, so therefore SSAD is unlikely, plus you can do serum vitamin B12 levels also. Along with this, I can also go for antibody profiles in the patient, though it is not a necessity to do them because lots of time facilities may not be available. Even if you call up a big laboratory like Lal Path Lab, which is a private laboratory that you're aware of, you will notice that they are collecting samples of CSF for this particular test, but they will give the report maybe after 7th of the next month, which means that I cannot obviously wait that long. So the antibody tests are being discussed only for academic reasons and are not important from the perspective of actually making a diagnosis in a government hospital. I will definitely teach you the diagnostic criteria, but it is first my responsibility to tell you what are the antibodies seen in this condition which are causing trouble. You need to remember 3 names. As I highlighted, most of the time, most labs will not be having facility to test for these antibodies or their titers. It is mainly for academic reasons that you need to remember that anti-GM1 antibody is the villain which causes motor plus sensory plus autonomic manifestations, AIDP. Anti-GQ1 antibody is the villain behind development of Miller-Fisher syndrome, where there was a triad of ophthalmoplegia, areflexia, ataxia, but minus the arm weakness. Anti-GD1 antibody is the one responsible for AMAN, that is acute motor axonal neuropathy. I'm just putting a small line over 3 and 4 to say that these are not mandatory for diagnosis. I mean, if you have a facility, cool. If you don't have a facility, no problem. Don't fret about it. You can still make the diagnosis. So let's study what are the diagnostic criteria for Guillain-Barre syndrome. And this is itself an MCQ that I'm writing before you. Brighton criteria are useful for diagnosis of answer is GBS. The first and the foremost thing which has to be remembered here is development of a bilateral flaccid paralysis. It has to be a lower motor neuron manifestation developing in the patient, which would be developing initially in the lower limbs and then will be going up. You must be able to demonstrate a distal areflexia. I'm not mentioning areflexia whole of the body because initially when he will come to you, there might be only ankle jerk disappearing and maybe the knee jerk might be slow, and after one day even the knee jerk will disappear. When it comes to the clinical course of the disease, there would be a deterioration of the patient over a span of hours to weeks, but not definitely years. If I'm talking about weakness in the legs, which is developing over years, then we could be thinking about amyotrophic lateral sclerosis, a motor neuron disease, which has been discussed subsequently in the app. In this particular case, you will notice that the monophasic illness would span something over 12 hours to 28 days, that is approximately 4 weeks. Like in the first week, there could be paralysis only of the legs. So they went to some RMP doctor, they went to some Ayurvedic homeopathic. Then the paralysis came to trunk. That is when they got alarmed and they came to you, or maybe they still continue going to that Ayurveda homeopathy, and then he started having arm weakness and had breathing difficulty. That is when they realize something is seriously wrong with this guy. So you might get cases where the progression might be over a couple of days. You might get cases where the progression might be over a span of weeks, but it's going to be upper limit of 4 weeks for diagnostic criteria. So remember, onset to nadir, which basically means the progression of the disease per se, can span over the time frames that I've highlighted. You will then have to supplement the diagnosis by doing electrodiagnostic tests. So he's not asking to you to do a MRI spine in all the cases. He say even if you have facility for something as simple as a nerve conduction velocity and the F reflex latency in the report is increased. Latency period simply means time taken for the current to go into and back, to and fro movement is hampered. You will supplement this by doing a lumbar puncture, and the lumbar puncture of the patient will be showing a albuminocytological dissociation. As I have warned you earlier, don't too much rely on the word albuminocytological dissociation alone. It is a combination. So these are the 5 things that I wanted to remember in the Brighton criteria, and in fact I would rate this as the most important slide of this particular discussion that we're having at the moment. And if you get a hang of this, you definitely will be able to crack the question right on reading it. It's going to be maybe a 2 or a 3 liner question. This word AC dissociation is usually not given. He's going to try to waste more precious seconds of yours by writing the complete CSF report of the patient. Now is the time for treatment. Do not answer steroids. Rather, steroids are not going to help in this case. And when I say that, the usual queries are, one hand you are saying autoimmunity, type 4 hypersensitivity. Why not steroids? You see, steroids are going to prevent the formation of antibodies and immunological response in future, but it's not going to handle the current load of antibodies. You see the antibodies circulating in the bloodstream, attacking the spinal cord and attacking the peripheral nerves. I want to clear them. So to clear them, I will be giving intravenous immunoglobulins. Now, intravenous immunoglobulins are obviously expensive. I mean, the treatment can go up to as much as 30,000-40,000 rupees depending on the brand for a duration of 5 to 7 days. So I can definitely say that the treatment of this condition is relatively expensive, but yes, we will have chances of recovery. If you say what are the chances of recovery, yes, I'll be very positive here. Up to 85% recovery will occur in GBS. This figure you don't need to remember. I just wanted to sensitize you that over the next couple of weeks to months, he will require a lot of intensive physiotherapy, lot of willpower, lot of support on the part of the family, and he will be able to get back on his feet again. Now, this might look good from a doctor's perspective, but think from the family's perspective. If this guy was the only earning member of his family and he developed paralysis and the family has no savings, no insurance, they would not even have the money to eat. Forget about getting costly treatment done for this guy. So economics is a big problem in our country, where obviously the government will not be subsidizing healthcare for this particular chap. Do not answer steroids for this condition because of the reason that I explained to you, because steroids can prevent the future formation. It can prevent the future insult from occurring, but whatever is the damage, you see, if there's a problem right now, you have to handle the problem. No, you'll not say, I will prevent the problem from occurring. I first have to treat the problem right away. Then another query that I get from a lot of doctors is that we have read about plasmapheresis also being used for this condition where we can remove the harmful antibodies. True, plasmapheresis will require relatively more aggressive setup. I mean, you need a proper setup for this, right? As a result of it, on a comparison basis, if he just says drug of choice or treatment of choice, I will answer this as intravenous immunoglobulins only. Please remember, efficacy of both of them is equal. It's not that IVIG is superior to plasmapheresis. Both are gonna cause a similar magnitude of improvement. It is only that IVIG is relatively more practical because you just need to put in an IV line and give the molecule that will clear the antibody, versus plasmapheresis, which will require an intensive setup, which may not be available in all the scenarios, or at least in most of the district hospitals or tertiary care hospitals. Plasmapheresis facilities are not there. If you rule out, I would say teaching hospitals. So the main treatment of this patient would be answered as intravenous immunoglobulin, and apart from that, ventilatory support is of paramount importance for this guy, and lots of time tracheostomy would be done, and therefore speech rehabilitation would also be required. I now want you to compare the manifestations of Guillain Barre syndrome with that of transverse myelitis. As the name suggests, this is going to be again an inflammatory disorder because the word itis is given. Initially, he will describe a person having an upper respiratory tract infection or a gastroenteritis. He went to the physician who prescribed him ORS, maybe zinc supplementation, and the person has recovered. At this point, this particular gentleman is not even aware of the fact what's going to happen to him subsequently. After a variable period of 2 to 4 weeks, the antibodies which are produced in this condition will contribute to development of inflammation of the spinal cord. Last time I was using the word segmental demyelination, patchy demyelination. Now I'm using the word inflammation, which tells you the fact that steroids will be useful in this condition. He will describe this patient waking up in the morning with inability to move his legs or get out of the bed. There would be a flaccid paraplegia. Subsequently, though he tried to get out of the bed or the chair by using the power of his arms, he fell down. Initially, he could at least sit in the chair, but now truncal paralysis has also occurred in this guy. The clinical presentation of this question will be identical to that of GBS. However, there are certain pointers which will definitely be helping you in picking up this particular disease over GBS. Let us look at what are those. He will talk about quadriplegia, describing diaphragmatic paralysis and the need for intubation in this person because carbon dioxide values are rising. But now will come a very characteristic manifestation, which is sensory profile. Now, the reason why I have changed the color of the ink here is to highlight that when you ask the sensory complaint of this person, he's not going to talk about pain in the muscles. He might say, doctor, I feel as if somebody has poured acid over my legs. He might say, I feel as if somebody's taken a blade or a piece of glass and is making cuts over my legs. He might say that I feel as if somebody's pouring boiling water over my legs. So the word that I'm gonna make you remember here is radicular pain / root pains in a patient. I can also use terms like lancinating pain, burning pain, and most peculiar thing that will come up would be that he might put his hand like this. If his hands are working, if he's not had quadriplegia at the moment, he might put his hand like this, maybe at the level of ZP sternum, or if I go down, maybe at the level of the umbilicus, and might say that below this level, I feel as if my body is burning with acid, and above this, I'm okay. So there will definitely be a sensory level that you will document in this particular case. Unlike in GBS, where he was just talking about a vague musculoskeletal pain, like the kind of pain that comes after doing little bit of more workout or exercise. In this case, the words are very characteristic. I feel as if somebody is tying a metal wire, that military grade barbed wire, no? He says, sir, somebody is tying a military grade barbed wire around my legs and is trying to cut them. The wire is cutting into my legs. That's the kind of feel or description that this guy can give. So the sensory complaints of these patients will be very, very dramatic, to the level that the person might come or might go and develop tears as well. Then autonomic malfunction can also occur. That's a common thing between the two, so therefore I've used the saming. Autonomic insufficiency, autonomic dysfunction is seen both in GBS as well as in transverse myelitis. So he can use the word widely fluctuating blood pressure, labile blood pressure of the patient, and when he describes the vitals, don't be surprised if the heart rate and the BP is given to be on the lower side. Now comes another difference which I have highlighted earlier, which is that bladder and bowel involvement is usually seen in transverse myelitis, whereas usually is not seen in patients of Guillain-Barre syndrome. In fact, I'll speak a few more words about the bladder involvement in this case, which is very characteristic. So let us take this to be the representation of the nerve root S2, S3, S4. This is the representation of the urinary bladder. This is the detrusor muscle that will contract on stimulation, and therefore the urine will be ejected into the urethra. The structure that I've shown here is the internal urinary sphincter, and this is the urethra of the patient. What I want to highlight here is that when approximately 50 ml of urine is accumulating in the bladder of a normal person, then there is definitely an awareness, like person can at least sense that there is something in the bladder. But once the amount starts exceeding 150 ml of urine, then in a normal human being, there will always be an urge. The person may get up from his chair and will go to the washroom, urinate and come back. During this urination part, the detrusor muscle will contract. The internal urinary sphincter will relax, and therefore this urine will definitely pass out into the urethra because of the contraction of the detrusor and relaxation of IUS. But in this case, the problem is S2, S3, 4 is damaged. Because of damage to S2, S3, S4, there will be no awareness, there will be no urge in this guy. I mean, in this guy, the bladder could be totally filled with urine. Do you see the maximum capacity of the bladder is 500 ml? The bladder could be completely filled with urine, but this guy is not gonna feel as if there's urine present in the bladder, and therefore he will not make attempt to even pass the urine. Now comes the critical aspect. This is a denervated bladder. You see the nerve supply to the bladder is cut, but the muscle also knows to contract. No, I said a nerve is supplying a muscle. Even if you cut the nerve supply to a muscle can also contract. No, so when the bladder is dilated to the hilt, when the bladder is full to the hilt to this maximum capacity, the bladder can contract on its own, and the person will pass urine in his clothes lying in the bed itself, which will soil the clothes of this guy, will create an unhygienic situation. So this presentation that I'm making before you is technically called as overflow incontinence. In this overflow incontinence, I'm not saying that all 500 ml of urine, that's the maximum capacity of the bladder, all 500 ml will pass out. Maybe only 300 ml, maybe only 400 ml might pass out. 100 ml might still be left behind. So therefore, you will always notice the word written post-voidal residual urine. Traditionally, you read about post-voidal residual urine in benign prostatic hyperplasia where there is obstructive uropathy. But today, I am teaching you that this particular patient who is having a autonomous bladder. Why am I calling it an autonomous bladder? Is because the bladder is contracting on its own, without a nerve supply also. That is because the muscle also has the ability to contract. Mainly the term that I wanted you to remember for this guy is, one, the term overflow incontinence can be seen in this patient. Second is the word autonomous bladder. Now before we go forwards, let's have a look at this information once again so that I can give you information regarding damage above S2, S3, S4 also. Let us say this is the root value of the bladder. The structure that I've shown here is the internal urinary sphincter. This is the urethra. And when there is about 150 ml urine in the bladder, that is when the awareness component would translate into urge and the person will make an attempt to urinate. Now what I'm saying is that suppose the damage is above the level of S2, S3, S4. I'll just write it for your convenience. The lesion is not in S2, S3, S4. The lesion is above S2, S3, S4. That means that we are talking about upper motor neuron lesion, right? We are talking about the control of the bladder being gone. The control that comes from the brain. In these circumstances, now see what will happen. Whenever the lesion is above, there would be spasticity. So I am going to draw here a spastic bladder before you. You see, this is a relatively a contracted bladder, a spastic bladder. Last time when I was cutting the nerve supply of the bladder, there would be a lower motor neuron bladder, there will be a flaccid bladder. But in this case, I'm showing a spastic bladder. And because this is a spastic bladder, therefore normally I said urge comes at 150 ml. Imagine if the bladder is contracted, then the urge will come at less than 150 ml. Therefore, the manifestations of this person will be that he will urinate every few minutes. Urge incontinence. In fact, I've highlighted this even in my initial discussion of stroke, that whenever there's damage to the brain, there can be development of urge incontinence in an individual. You can just remember it from alphabet U. Upper motor neuron lesion results with respect to the bladder results in urge incontinence, where the person will urinate after every few minutes, just like a little baby urinates after every few minutes. No, you have to put nappies in a child. So the term here used is automatic bladder. My objective was to not only teach you about transverse myelitis, but also to teach you about these two terminologies by the name of automatic and autonomous. You can remember one of them. I can suggest you at the moment to remember the word automatic, just like a little baby's bladder contracts after every few minutes, or let me say every hourly, and the baby urinates without any warning and soils the nappies. Similarly here, the bladder is behaving like that of a little baby. And when will it occur? When the brain control is not there. Little baby, you can imagine, controls are not developed well. So as a result of it, automatic. Whereas in the previous scenario, which was actually the topic transverse myelitis, the nerve supply to the bladder is gone. So the technical term was lower motor neuron bladder, denervated bladder. The bladder knows how to contract, but right when it is stressed to the hilt. So without warning, out of 500, 300, 400 ml urine might pass, and that will again cause soiling of the clothes of the person. The technical term I want you to remember would be sensory involvements are very characteristic of transverse myelitis, to the level of words written like sensory level, root pain, radicular pain, or he might actually describe it like somebody is cutting my legs with a piece of glass. And then the bladder complaints of this person would also be very, very characteristic. If he says what is the best way to confirm the diagnosis of transverse myelitis, to demonstrate the myelitis component here, I need to do a MRI spine. The MRI spine will definitely give a signal of inflammation and contrast to demyelination in the previous disorder, which explains the fact that why will we be using steroids for this case. You will notice that earlier I was very vocal about not giving steroids. Now I'm being very vocal about giving steroids for this case. In fact, this is itself a question that IV methylprednisolone is used in. It's not GBS, it is transverse myelitis. The next part of the discussion, I just want you to listen to me at the moment and not note down anything. You see, I've described a person having paralysis of the leg, then of the trunk, then of the arm, then of the neck serially. So let us assume there's a patient who woke up in the morning. So I'm saying when he woke up first hour of illness, that is when he realized something is wrong. In the first hour, he was having paralysis in both his legs. By afternoon or evening, the paralysis has spread to the trunk. There's a possibility that then arms might be involved, then even neck may be involved, and he might even become ventilator dependent. Let me change the scenario. On the first day, the patient was having paralysis of his leg. Maybe by the second day, the paralysis developed in the trunk, the third day in the arm, and fourth day in the neck, and so on. There is also a possibility that person was having paralysis of both his legs in the first week of illness. They were showing to some Ayurvedic, homeopathic, no improvement. Then the paralysis extended to the trunk. He could not sit in the bed. That is when they decided to see you, and when they saw you or sought your consultation, arm paralysis was developing, and then neck floppiness also occurred in the patient in the course of illness. My objective of writing these numbers is to sensitize you to the fact that the illness in Guillain Barre syndrome can span over hours, days, and weeks, as I've told you, a range of 12 hours to 28 days. So if they give you a clinical question where the same kind of clinical features that I have just explained to you are present, but he mentions that the duration of illness, listen to my words very carefully, but the duration of illness is given to be, let me say, 9 weeks or 8 weeks, then in these circumstances, the diagnosis will be given not as Guillain Barre syndrome and neither as any of the 4 variants of Guillain Barre syndrome. Your answer will be given as chronic inflammatory demyelinating polyneuropathy. The main carry home message from this particular slide is that whenever you are going to read about manifestations of ascending paralysis, don't be biased to jump the gun and answer GBS, because there's a possibility there's a trick in the question. And what is the trick in the question? The trick is the duration of illness is not going to be the standard hours, days, and up to a 28-day period. It's going to be much more. It's going to be spanning over a much more longer duration. Then you will say chronic inflammatory demyelinating polyneuropathy, where again steroids will be answered. So 2 scenarios which I'm teaching today where steroids are a yes. Earlier I was saying a big no to steroids. Now I'm highlighting the usage of steroids, and those are the points that the examiner wants to listen from you. That transverse myelitis and chronic inflammatory demyelinating polyneuropathy is where methylprednisolone can be used. Let me make you practice this CIDP thing once again so that this becomes a permanent memory for you. What I've taught is that this disease can mimic the features of Guillain Barre syndrome, and the presentation of the case has been discussed, the ascending paralysis in a fashion that it's hard to miss. The highlights in the question will be same. That would be a symmetrical flaccid paralysis developing in the person. The worsening period will, however, be different from what I was saying earlier. This is gonna be over a duration of months in most of the cases. If you will do a nerve conduction velocity, in this case, there will again be a conduction slowing present. So either he might say increased latency periods, or he might just use the casual word conduction slowing is present. Now, the reason why I've highlighted this is mainly to sensitize you to the fact that albuminocytological dissociation can be given even in a MCQ or CIDP. So now 3 times I've said the word albuminocytological dissociation. AIDP, the GBS standard versions, including when I said Freund syndrome, and now CIDP also. Now, what will be given in the question apart from duration that can help you with the diagnosis is this term. In fact, what I'm teaching you next is itself a question. Nerve biopsy in this particular case might be showing a onion bulb appearance. Well, I can say that onions are, mostly loved by pathologists. You read about onion peel appearance of blood vessels. You read about the bile ducts having onion peel appearance. But in this case, the onion bulb appearance is because of the repeated myelination and the demyelination aspect. You see, there's a demyelination. The body is trying to compensate by causing a remyelination. So the demyelination and the remyelination aspect explains the onion bulb appearance in this case. In fact, I want you to be sensitized to the fact that onion bulb appearance in the nerves in a nerve biopsy can also be read in hereditary sensory motor neuropathy, HSMN. Hereditary sensory motor neuropathy is also called as Charcot-Marie Tooth disease, and this is discussed in the subsequent part of the app where I've talked about Duchenne's muscular dystrophy, Becker's dystrophy, and then even a congenital neuropathy as well. The main focus I want you to remember is the duration part and the nerve biopsy finding, and it's mainly that I wanted you to get sensitized to the word onion bulb, that I've spoken about this again. You are aware that in primary sclerosing cholangitis, you could be having an onion bulb appearance related to the bile ducts. Onion peel appearance of blood vessels is what you read with malignant hypertension. But then, yes, the important details are what I have highlighted. To finish the topic, I'll do a quick comparison of Guillain Barre syndrome versus transverse myelitis versus poliomyelitis and then botulinism. The last 2 entries that I'm mentioning at the moment would be having descending paralysis and would be mainly pediatric cases, but still it's worth the effort to actually just compare these 4. In GBS, the initial trigger could be in the form of dysentery. Subsequently, he will talk about ascending symmetrical paralysis. There will be no root pains in this case. The sensory complaints of these patients will be limited to mainly only the word sore muscles or pain in the muscles that can come after exercise. But when it comes to transverse myelitis, he might talk about a standard URTI, acute gastroenteritis. Remember, if he talks about jaundice, then again that is to be thought in terms of GBS, because hepatitis C is one of the leading causes of acute viral hepatitis, and later on neurological features will occur. In transverse myelitis, the same features will occur, but the differences is what I've highlighted. Root pains will be present, sensory level will be present, bladder and bowel involvement will be present. By bladder plus plus and bowel plus plus, I mean that they would definitely be involved in the form of incontinence. When it comes to poliomyelitis, initial manifestation of poliomyelitis might be simply development of fever, but later on there will be a development of a asymmetrical descending paralysis. And in fact, in poliomyelitis, there's a possibility that the paralysis might stop by itself also, and maybe only one leg would be involved. Like poliomyelitis patients, they will have a disability in one leg only, so they might be walking with crutches or they might be walking with a stick. When it comes to botulinism, there will always be history given of home delivery and then subsequently honey being given to the child, and when the mother is now feeding the child, the milk is coming out of the nose. The manifestations of botulinism will be mainly that of bulbar palsy. The child will be choking on the breast milk. The child will be having nasal regurgitation of fluids, and when the child will cry, voice will not be coming. That is definitely a high risk for aspiration pneumonia in botulinism primarily. So on a comparison basis, when you talk about paralysis word per se, then all these illnesses have to be considered. Obviously, the extreme right hand side will be purely a pediatric cases, and apart from that, the paralysis in these patients will be very fast in onset. If you get a question in which the paralysis in a person is developing over years, like let me say hypothetically at the moment, you can just listen to this fact: the paralysis is occurring in one leg. This is, let me say, in year 2020, the paralysis occurred in the left leg, and he was walking with the help of a stick because one leg is becoming useless. And in 2021, the paralysis is occurring in the opposite arm. Then the disease that you need to take into consideration is motor neuron disease. This I've discussed in the subsequent part of the app with the example of Stephen Hawking, the great astrophysicist who was suffering from amyotrophic lateral sclerosis. In fact, the important bit of history is that in amyotrophic lateral sclerosis, usually patients die within 3 years with respiratory failure, but Stephen Hawking was the longest living survivor with the disease. He was taught, or he was told by his doctors the diagnosis of motor neuron disease way back in 1975. He expired in 2018, and in fact he allowed his body to be used for testing for various drugs which are currently being used for motor neuron disease. So you can definitely go through this discussion subsequently, but the message is that it would be again asymmetrical but would be slow in onset, and this disease would be attacking the anterior horn cells of the spinal cord. It would be pyramidal neurons in the brain that would be affected, but higher mental functions definitely remain normal. So motor neuron disease can be imagined like this: the body is not working, but the brain is working. Whereas in Alzheimer, it is ultana. In Alzheimer, the brain is not doing normal things, and the body functionally is perfectly fine. These are the details, guys, that I want you to learn for this topic. Pretty interesting one, Guillain Barre syndrome, and most of the questions can be solved on the basis of information that I've provided. And keep learning, keep upgrading your knowledge on a regular basis. Try to do questions on a daily basis. Try to do them with speed. I mean, doing 50 questions in 50 minutes is big deal. Doing 50 in, let me say, 3 hours is not a big deal. So time is also essence. I mean, apart from speed, accuracy, definitely you can build this over a period of time, and it's not going to come overnight. If you think no, that you're gonna finish the entire course once and then you wanna come back to MCQs, no. You do a question, you do a topic, you do questions related to that, and maybe the first time when you do those questions, you may not be able to solve them because they've been designed in that fashion that you're gonna get them wrong. So don't fret over it that okay, I got only 40% right, or I got only 50% right after listening to the lecture once, because you need to listen to these facts again and again. You see, and then the long-term memory tends to build up. That's when you start interlinking various disorders, and then you are able to apply them in the final exam. So thank you so much, guys, for hearing me out and having the patience to listen to my terminal part of the discussion as well. Thanks.